The last 6 months have borne witness to the most disruptive global event since World War II. COVID has changed the way that we as a society work, educate, deliver healthcare, travel, and live. The global death toll is now pushing 1 million. Millions of people have lost their jobs, and with them in the US, their health insurance, and many face eviction and food insecurity. As governments are committing trillions of dollars to relief and stimulus packages in an attempt to mitigate the economic fallout, many are seeing this as an opportunity for a global reset, a chance to rethink how we structure our society and to chart a new course for decades to come. In May, an open letter to the leaders of the G20 was signed by 40 million healthcare professionals, or 2/3 of the global healthcare workforce, advocating for a healthy recovery and calling attention to the ways in which human health is dependent upon a healthy environment. Antonio Guterres, the UN Secretary General, argued in a New York Times opinion piece in April that this is an opportunity to build more sustainable and inclusive economies and societies, and that current investments must accelerate decarbonization. He proposed a suite of climate-positive actions governments should include in their pandemic responses. The WHO published a manifesto comprising 6 prescriptions for a healthy recovery, including heightened environmental protections, sustainable food systems, healthy urban design, clean energy, and an end to fossil fuel subsidies. Everywhere we're seeing calls not to return to quote unquote normal, but to build back better. The pandemic has shone a spotlight on the concept of planetary health, which is a relatively new field of study, and it's a collective term that encompasses both human health and the natural systems that underpin it. Even at the height of the first COVID wave, the head of the WHO, Tedros Ghebreyesus, refused to view the pandemic as unrelated to planetary health, saying that any efforts to make our world a safer place are doomed to fail unless they address the critical interface between people and pathogens and the existential threat of climate change. Now, just as governments must make decisions on a societal level that determine population health, so we as a healthcare organization have an opportunity to map out a healthy recovery. This includes reimagining the way we deliver care, how we interact with our local community, and the impact of our organization on local and global environments. It's a unique opportunity to embrace our mandate as a healthcare organization to not only treat disease, but also create health, and as our motto suggests, to promote wellness. A healthy post-pandemic recovery for VGH should embed planetary health principles in our organizational structure and in our everyday activities. Now, we in the Lower Mainland have the good fortune of being ahead of the curve in this realm, thanks to the phenomenal efforts of our energy and environmental sustainability team. Under their leadership, our greenhouse gas emissions have declined to 18.8% since 2007. Energy intensity has decreased by 13%, and an ambitious zero waste and toxicity strategy is under development. So what's the scope of the opportunity here? Healthcare is responsible for 4.6% of global greenhouse gas emissions. And that may not sound like a lot, but to put it in context, aviation is responsible for 4.9%. So decarbonizing healthcare would be equivalent to eliminating air travel altogether. If the health sector were an independent country, it would be the 5th highest emitter in the world. In addition to climate impacts, healthcare activities generate air pollution, massive amounts of solid waste, and uniquely toxic biohazards that contaminate soil and water. The US was the first to publish national estimates of healthcare emissions, and they found that healthcare is responsible for a full 10% of greenhouse gas emissions in the US. The public health damages estimated to result from this level of pollution are approximately 614,000 disability-adjusted life years, which is on par with the harm created from medical error. But while a billion-dollar industry has arisen to mitigate the threat of medical error, the same attention has not been devoted to healthcare's environmental footprint. The authors conclude that healthcare pollution should be considered a patient safety issue and should be incorporated into quality improvement efforts. In 2018, we became the 3rd country to publish our national healthcare emissions, coming in at 4.2%. And while in absolute terms, this may be on par with global average, we actually have the 3rd highest per capita emissions in the world. These data are from the 2019 Lancet Countdown, which is an annual reporting structure on a number of climate and health metrics. And the finding was so significant that it was highlighted as one of the top 3 actionable issues for Canada in the accompanying policy brief. And our recommendation was the creation of a multidisciplinary pan-Canadian initiative to chart a course toward net zero healthcare emissions. Only 2 months later, in January this year, the NHS announced a commitment to decarbonize well in advance of the nationally mandated target of 2050. And this has set a powerful precedent for other health systems. Myself and Fiona Miller, who's a professor of health policy at the University of Toronto and the founder of the Centre for Sustainable Healthcare Systems, have initiated a Canadian campaign to achieve a similar commitment at both federal and provincial levels. The logical question is how we get to net zero and what a sustainable healthcare system actually looks like. And the answer is first and foremost, not recycling, which is the universal visceral response and a source of great frustration for me and other people in this space. If we want to take meaningful action at the scope and scale required to avert catastrophic climate change, we have to do a whole lot more than sort our garbage into different bins. So I'm going to present to you a three-tiered approach to sustainable healthcare, beginning way upstream of the recycling bin. The first thing to understand is that every healthcare activity has a footprint. Every test you order or treatment you provide consumes energy and materials and generates waste. So the highest yield strategy for reducing the healthcare footprint is to reduce the demand for health services. And this brings us back to the idea of a healthy post-pandemic recovery and the way that the decisions made today will determine the health of our society for many years to come. The WHO recommends a health in all policies framework in which decisions regarding transport, housing, employment opportunities, and livable incomes are all informed by their impacts on population health. The healthier people are, the less reliant they will be on healthcare systems, which is the biggest determinant of both the environmental and economic sustainability of these systems. Here are some examples of planetary health strategies that reap simultaneous co-benefits for people and the planet, promoting health and reducing the demand for health services. Encouraging active transport, like walking or cycling, with supportive urban planning and organizational structures like commuter centers, leads to obvious health benefits like reduced obesity, cardiovascular disease, and diabetes. Furthermore, they enhance urban air quality, leading to decreased respiratory illness and cardiovascular disease. One of the possible benefits of the pandemic is that expanded access to active transport might persist, with many cities permanently expanding their cycling and pedestrian infrastructure and banning cars from city centers. VCH is already performing admirably in this area with the commuter center and with the Go Orca carpool scheme. The new Canada's Food Guide has been celebrated for its evidence-based recommendations and adherence to a planetary health diet, with emphasis on plant-based protein, portion control, and the sociocultural aspects of eating. Widespread access to proper nutrition and adherence to these recommendations would be expected to impact on the burden of obesity-related illness, cardiovascular disease, and cancer. Food security and resilient food systems have emerged as a top issue from COVID, as the loss of income and disrupted supply chains have threatened many people's access to adequate nutrition. And I'll speak more to what VCH can do in this realm later. Policies that reduce greenhouse gas emissions, improve cardiorespiratory health, and decrease cancer incidence. The Canadian Association of Physicians for the Environment, under the leadership of its past president, Courtney Howard, shown here, was one of the key driving forces between the federal government's accelerated coal phase-out, which is a commitment to decommission all coal-fired power plants in Canada by 2030. In their description of the policy on the government website, they specifically cite the anticipated health benefits and recovered healthcare costs as rationale for this decision. In June, the International Renewable Energy Agency released this roadmap for an accelerated clean energy transition as part of a healthy recovery, showing that investing in low-carbon energy infrastructure now would be job-creating and would stimulate the economy much more than ongoing oil and gas subsidies. The cost of investment would be recovered eightfold by the healthcare system. Now, you may feel that these issues are outside of your lane, but health promotion is part of our core mandate, and health professionals are society's most trusted messengers. Now is the time to leverage that moral authority and advocate for healthy policies that will protect the planetary systems on which our health depends. Some of our colleagues are leading the way and deserve special credit for their efforts. Rashmi Chadha is a pain and addiction specialist here at VGH who began a local Extinction Rebellion chapter of health professionals. And this group of fearless advocates has drawn attention to the health damages of things like the Tilbury LNG expansion and logging of BC's old growth forests, and they're working to hold politicians to account for the health of the public. The aforementioned Courtney Howard, who is an emergency physician in Yellowknife, has been one of Canada's loudest physician voices on behalf of Planetary Health for the past decade. She recently decided to take her advocacy to the next level and is one of 8 candidates for the leadership of the Federal Green Party, running on a platform of a healthy recovery and transition to a wellness economy. I think Courtney would be a visionary and compassionate leader, and I wholeheartedly support her in this race. Now, these are both examples of extremely engaged health professionals, but I would encourage you all to contemplate how you might use your respective platforms to promote health. And thus far, I've given examples of primary prevention or strategies that prevent disease. But secondary prevention is the next most impactful level of intervention because this reduces the intensity of care required. And cancer screening programs are a good example. Think about the cost to the patient and to the system of treating a colonic polyp as opposed to a full-fledged colon cancer. Cost of care is usually a good proxy for environmental cost because it reflects resource intensity. So polyps are detected and treated by colonoscopy, which is a half-hour outpatient procedure under sedation, costs the system about $600. In contrast, the average cost of colon cancer treatment in Canada is around $44,000. This usually involves surgery, often 6 months of chemotherapy, and in the case of rectal cancer, can involve radiotherapy as well as a second operation for stoma closure. Hemodialysis is an area that's been well studied from an environmental perspective. The carbon footprint of hemodialysis is between 3.8 and 7.2 tons of CO2 equivalents yearly, which is analogous to driving 28,000 kilometers. It's also a costly intervention from a health system perspective at $60,000 per patient per year. So imagine if some of those resources were redirected toward primary care to ensure that patients take their blood pressure medications and manage their diabetes, such that some of them never progress to end-stage renal disease. This is clearly a better patient outcome, as well as better for the health system and the environment. The next principle of healthcare sustainability is ensuring high-value care. And this takes the well-established notion of quality of care and it incorporates cost. A high-value paradigm recognizes that we do not live in a world of infinite resources. Costs of care should include not only financial cost, but also environmental cost and public health damages. Our first maneuver should be to eliminate care that adds no value whatsoever. A 2017 report from Kai-Hai and Choosing Wisely indicated that 30% of care delivered in Canada is unnecessary. And this includes both investigations and treatment, such as people undergoing low-risk procedures who had unnecessary preoperative testing, people prescribed antibiotics for upper respiratory tract infections, or people who underwent surgeries that weren't indicated. And it also provides a cautionary tale about managing innovation, such as the introduction of robotic surgery for procedures in which there's no benefit over a laparoscopic approach. I mentioned the Choosing Wisely campaign, and I want to expand on this. Choosing Wisely is an international initiative to advance a dialogue on avoiding unnecessary medical tests, treatments, and procedures. They've partnered with over 80 medical specialty societies to devise evidence-based recommendations for the appropriateness and necessity of given tests and treatments. This approach to ensuring high-value care is captured in the notion of stewardship, which we're most familiar with as it relates to things like antibiotic or opioid prescribing, but should be extended to stewardship of all healthcare resources. We undertook a study around stewardship of laboratory investigations in general surgery, and I'd encourage you all to think about what areas of your own specialty or practice might benefit from this type of review. This work was done by 2 of our general surgery residents, Annie Lalonde and Karina Spoialo, in collaboration with Dr. Sophia Wong from Lab Medicine. They looked at blood work in a subset of our acute care general surgery patients. As shown here, unnecessary blood work has cost to the patient, the hospital, and the planet. We identified populations of what we would consider bread and butter acute care general surgery, appendicitis, biliary stone disease, small bowel obstructions, and we established what we felt were ideal ordering pathways. So this includes things like no postoperative blood work in uncomplicated appendicitis and cholecystitis, and no trending lipase in gallstone pancreatitis. We then compared actual blood work performed to these ideal pathways and found that 76% of patients underwent unnecessary blood work. In this population of select general surgery patients, we performed 1,200 unnecessary blood tests per year at a cost of $10,000. And when we extrapolated these results to the whole hospital, we estimated that VGH disposes of 58,000 excess plastic blood vials yearly from tests that add no value. We're working now to develop best practice guidelines for our trainees to encourage this sort of resource stewardship and to avoid the all too common finding of days and days of normal labs in PCIS. Unnecessary care and inefficient resource utilization can be further avoided by the way in which we design our care delivery. Michael Porter from Harvard Business School is a thought leader in organizational strategy, and he wrote this boldly titled manifesto, Advancing a High-Value Care Agenda, suggesting that healthcare would be better organized around the integrated treatment of disease than individual professional practices. Under the leadership of Dr. Morad Hamid, we've taken this blueprint and transformed the division of general surgery into integrated practice units, in which team-based care is delivered in a way that streamlines and optimizes the patient experience and outcomes. The paradigm includes familiar concepts like multidisciplinary clinics that allow a patient to see multiple specialists or allied health providers in a single coordinated visit instead of making multiple trips. Going beyond VGH, here's an example of high-value care principles applied at a provincial systems level. Our recently graduated surgical oncology fellow, Dr. Seetha Alak, looked at patients with retroperitoneal sarcomas across BC, and she mapped the patient journeys. These patients typically present to their family doctors or emergency departments, are referred to a local surgeon of any number of specialties, who usually orders an array of tests and may even undertake exploratory surgery, and they're eventually referred on to another specialist until they eventually reach definitive care. We found that some patients saw up to 7 specialists before arriving at their definitive treatment provider. Virtually all had unnecessary testing, including 27% who underwent unnecessary surgery at a median excess cost of $20,000 per patient. Unsurprisingly, this circuitous process results in delays in accessing definitive care, with median time from first presentation to treatment being 14 weeks. We're now working to implement clinical pathways to expedite these patients' arrival at definitive care and to eliminate all unnecessary steps, which will not only result in cost and carbon savings, but also provide more timely care, improve the patient experience, and potentially improve their oncologic outcomes. Virtual care is a hallmark of a sustainable healthcare system because it displaces more resource-intensive in-person interactions with remote communications. So this includes both synchronous communications, which are real-time interactions either by phone or video platform, or asynchronous communications like email or text messaging. Virtual care can be facilitated by EMRs with enhanced remote communications capabilities and mobile apps that can potentially avert the need for clinic visits with a quick message exchange between patients and their provider or support staff. Multiple studies have shown these to be more convenient for patients and more cost-effective than in-person care, to say nothing of the avoided emissions of travel and resource utilization. Doctors Sheena McAdam and Catherine Isaac from Plastic Surgery and I are working on a navigational app for breast cancer patients that includes features like the ability to upload photos of their reconstruction for review by their surgeon in the early postoperative period, thus avoiding repeated clinic visits. The CMA's Virtual Care Task Force commissioned a survey in 2018 that showed that only 8% of Canadians had access to physician using virtual care. New results from June 2020 show that during the first 2 months of the pandemic, this number had risen to 57%, and that the satisfaction rate with these interactions was 91%. 38% of patients surveyed would prefer to maintain this option. Further guidance is available in the CMA's Virtual Care Playbook. One of the many positive legacies of the pandemic will be enhanced virtual care platforms, and I would encourage everyone to maintain these options going forward. Now, this brings us to the third principle of a sustainable healthcare system. Once you've eliminated unnecessary care, you can focus on optimizing the environmental performance of the care that is required. I undertook a Master's of Environmental Change and Management in order to investigate the environmental performance of the operating room. And the result was this study published in 2017. I'm going to show you some of the main findings and some of the actions that came of it. And I'd encourage you all to think of further actions that we could take. So we conducted a greenhouse gas inventory of operating rooms at 3 well-matched tertiary care academic hospitals, Vancouver General, the University of Minnesota Medical Center, and the John Radcliffe Hospital in Oxford. And the study was carried out according to the Greenhouse Gas Protocol, which is the industry standard for carbon accounting and reporting. The protocol recognizes 3 scopes of emissions. So emissions that come from directly within the organization, which in the OR is exclusively waste anesthetic gases, emissions generated due to energy consumption by the organization, and all other indirect emissions that go into the manufacture, use, and disposal of consumables used by the organization. Inhaled anesthetics are greenhouse gases. Their potency is expressed as a global warming potential over a 100-year time horizon relative to CO2, which is assigned a value of 1. The global warming potentials of the 3 currently used inhaled anesthetics, Sevo, ISO, and desflurane, are 130, 510, and 2450 times that of CO2. We took the purchased volumes of each agent over 1 year and calculated carbon footprints. The 2 North American sites had very similar emissions profiles at about 3 million kilograms of CO2 equivalents each. But notice that in spite of a much higher case volume, the UK hospital's anesthetic footprint was 10% of the others. This is entirely due to differential use of desflurane, which the UK hospital didn't even have on formulary because of cost. ORs require energy for heating, ventilation, and air conditioning, lighting, and all other electrical devices, which are collectively termed plug loads. We measured energy consumption due to HVAC systems, carried out lighting audits, and we sub-metered the ORs at each site to calculate an energy footprint. The left half of this table shows energy consumption in megawatt hours per year. VGH and UMMC were very similar, while JRH had considerably higher energy consumption due to the larger size of its surgical suite. But in spite of similar energy consumption, the carbon footprint at UMMC was 3 times that of VGH. And this is owing to differences in carbon intensity of the electricity supply. Minnesota's electricity is mainly coal-fired, while BC has some of the cleanest electricity in North America. The 20-fold difference in carbon intensity and electricity supply accounts for nearly all of the million kilogram difference in carbon footprint. Now, on average, HVAC requirements account for 50% of hospital energy consumption. Operating rooms have the highest HVAC standards of any area in the hospital, requiring 20 air changes per hour, as opposed to 6 air changes per hour in a ward room. As a result, HVAC requirements account for 90 to 97% of operating room energy use, which is helpful in directing energy conservation efforts. An accurate measure of the greenhouse gas emissions attributable to a product must take into account its full life cycle, from the extraction of the raw materials to its manufacture, use, reuse if applicable, and ultimately its disposal. Now, we did a lot of work on waste in this study, including waste audits showing that we generate 1,200 kilograms of OR waste daily at VGH, and we tracked the waste downstream to all of the processing facilities to calculate really granular carbon footprints. Ultimately, both at VGH and in Oxford and Minnesota, we found that emissions from manufacturing far outweigh emissions from waste management. These are the cumulative carbon footprints. The 3 sites each emitted between 3,000 and 5,000 tons of CO2 equivalents yearly. In North America, anesthetic emissions predominated, whereas in the UK, energy consumption was the main source of emissions. If we were to assume that the hospitals studied are representative of their respective regions, and we extrapolate these findings to the number of operating rooms within each country, ORs would be responsible for 9 million tons of greenhouse gas emissions annually, which is equivalent to 2 million cars on the road for 1 year. Now let's talk about actions taken since this study to lessen our footprint and what areas need further attention. Desflurane had been previously shown to have a disproportionate climate impact, which prompted Dr. Stefan Malherbe, who's an anesthetist at BC Children's, to embark on an educational tour around the Lower Mainland and advocate amongst his anesthesia colleagues for preferential use of sevoflurane instead. In 2018, he published this editorial showing that in 7 Lower Mainland hospitals from 2012 onward, Emissions due to waste anesthetic gases fell from 13.4 million kilograms of CO2 equivalents to 4.5 million. I think this is an astonishing result from a single intervention that really speaks to the engagement of the anesthesia community in environmental stewardship. Even better is avoiding volatile agents altogether in favor of alternative modes of anesthesia. This is work that my colleague Jody Sherman and her group have done at Yale, comparing different anesthetic strategies. Without going into detail, one can readily appreciate that anesthetics that involve inhaled agents, shown in the top two bars, have significantly higher global warming potentials than techniques like total intravenous anesthesia, spinal anesthesia, or regional block. At BC Cancer, we now carry out almost all of our breast cancer surgery under regional. And this not only minimizes the climate impact, but it avoids post-op nausea and vomiting, minimizes recovery time, and it eliminates the need for post-op opioid prescribing, which is another public health win. Another important finding in our study was in the area of energy conservation. We discovered that many hospitals don't titrate ventilation to usage of clinical spaces, and ORs are often aggressively ventilated when they're not in use. We modeled scenarios in which the maximum number of ORs not in use were scaled back to 8 air changes per hour instead of 20 after hours, and we found that we could cut energy consumption by half. We're extremely fortunate at VGH to have just gone through an OR renewal project with 16 new ORs opening in just a few months. And I want to congratulate and celebrate the project team for making environmental performance a priority in this process. Our new ORs will have anesthetic gas capture technology, such that any inhaled anesthetics used are not released to the atmosphere, but they're instead recycled for other applications or destroyed. The new HVAC system is a more efficient design than what we have currently, and it will include heat recovery as well as occupancy-based ventilation. Construction materials were chosen in part based on their environmental footprint, such as the flooring, which is carbon neutral throughout its entire life cycle. And attention was even paid to decreasing chemical toxicity from cleaning by using UV disinfection as much as possible. So a huge thank you to the project team, of which I think Kelly is in the audience today, for a massive leap forward in optimizing our environmental performance and creating a healthier workplace. The last bullet point you see here indicates that we're committed to preferential use of reusable over disposable products. And that's what I want to talk about next, coming back to the notion of consumables and waste. When we talk about sustainability, many people default to thinking about waste management. But we now know that up to 90% of a product's emissions are generated in the manufacturing phase. So the choice of consumables matters far more than how it's disposed of. It's time to move from the concept of waste management to waste avoidance, with the ultimate goal of zero waste. I want to familiarize you with the concept of circular economy. A linear economy is one in which raw materials are extracted and manufactured into products that are used once and then discarded. In contrast, a circular economy involves a cascade of loops to keep products in circulation at their highest value for as long as possible. And this is a hierarchy of loops, with reuse being the best option. An example of this would be steel surgical instruments that get steam sterilized and reused for decades. Some products need refurbishment or repair to keep them in circulation. And when no longer suitable for their original purpose, they can be repurposed for other applications. The lowest value loop is recycling, which only recovers base materials, and it requires considerable energy and material inputs. So recycling is not a panacea, and it does not absolve a person or an institution from its environmental responsibilities. Up to 70% of healthcare emissions originate in the supply chain, so this is the area where we can have greatest impact. We should be actively countering the trend towards single-use everything, as a linear economy is not compatible with a finite natural resource base. In the Division of Plastic Surgery, Doctors Peter Lennox, Nick Carr, and Mike Carr are investigating the application of circular economy principles to a specific aspect of breast surgery. When placing breast implants, whether for augmentation or for breast reconstruction after mastectomy, silicone sizers are often used as temporary placeholders to determine the optimal implant. Every year in Canada, approximately 30,000 sizers are disposed of after one use. The first principle of circular economy is reduction, so questioning whether the material use can be avoided altogether. which in this case involves careful preoperative biodimensional planning, including software sizing to anticipate the correct implant. The second principle is reuse. Sizers are approved for reuse, but for various reasons that's not currently done, but it could be undertaken to extend the lifetime of each product and minimize the number being discarded. Finally, if a single-use device is deemed necessary, an environmentally preferable option should be selected, which in this case would be an inflatable air-filled sizer rather than one filled with silicone. This hierarchical approach to material use is emblematic of the way we should all be critically evaluating our clinical choices. Many studies have documented the staggering magnitude of environmental savings from reusable medical products. Single-use surgical gowns consume 2 to 3 times as much energy, emissions, and waste as water as reusables, and they generate 7.5 times as much solid waste. And these provide an excellent example of how products can cascade through reuse cycles. Gore-Tex gowns are approved for 75 uses before they're no longer suitable for high-level barrier protection. After this, they can be repurposed as non-sterile PPE for isolation rooms or endoscopy, and they can be washed hundreds more times before they're no longer usable as gowns, at which point they can become fiber fill for industries like upholstery or insulation manufacture. The environmental benefits shown here only take into account the 75 life cycles as a surgical gown. So you can imagine that these are amplified many times more when used in a true circular economy. Another study out of Yale compared reusable to disposable laryngeal mask airways, and they found that disposable LMAs generate 50% more emissions than reusables. Importantly, life cycle assessments like this take into account not only climate impacts from greenhouse gas emissions, but other environmental impacts such as ozone depletion, water use, and air pollution. Disposable LMAs had higher impacts in every category, the most striking of which was carcinogens, with reusable LMAs generating only 5% as much as disposables. The vulnerabilities of a linear economy were laid bare by the pandemic, in which a shortage of PPE was the result of these items being single-use. Consequently, the only way to scale up supply is to purchase more, such that disruptions in manufacturing, in transportation systems, and even in international trade jeopardized hospital supplies. In contrast, had hospitals been equipped with reusable gowns and respirators, they would have only had to scale up their reprocessing cycles, which is typically a local phenomenon and much more easily done than scaling up manufacturing. Many hospitals, including VGH, developed reprocessing protocols for items that are meant to be single-use, like N95s. And this is laudable, and Titus Wong and his team in the PPE lab deserve a ton of credit for their innovation. But even better than ad hoc reprocessing protocols would be purpose-built, durable, reusable products designed for longevity and performance. With all of these principles in mind, the role of health promotion and disease prevention, ensuring appropriate high-value care, and optimizing our environmental performance, I want to share with you my proposed plan for how we can map out a healthy post-pandemic recovery and capitalize on our existing strong environmental performance to become a leader in planetary health. This is a work in progress specific to VGH right now, but these are universal principles that could be implemented across BC with time. This proposal represents my views for high impact action, and it's not currently endorsed by senior leadership in its entirety. The 5 pillars of the plan are hospital food transformation, integration of environmental metrics into quality reporting, stewardship, a circular supply chain, and clinical services mobilization. Annie Lalonde, the general surgery resident I mentioned earlier, has just begun a 2-year master's in the Institute for Resources, Environment, and Sustainability at UBC to look at the environmental and health benefits of implementing a planetary health diet for inpatients. We are partnering with executive chef and founder of Chefs for Oceans, Ned Bell, who competed against Rob Feeney on Iron Chef Canada, to develop an inpatient menu based on planetary health guidelines, and we'll trial this in a select population of general surgical patients. In addition to capturing the environmental benefits, we'll look at patients' nutritional parameters, short-term post-op outcomes, and experience. And there's also a longitudinal component in which we provide patient education on the environmental impacts of their food choices and follow up several months later to determine whether they've altered their dietary behaviors. I'm working with Alison Muniak and Don Grisdale from Quality and Patient Safety to determine how we might embed environmental performance in quality reporting, and with Dr. Jen Grant from Medical Microbiology and Infectious Diseases to expand the existing stewardship program to other clinical areas. As an example of what this might look like, St. Paul's has instituted an automatic 3-day stop date on daily blood work, such that blood work orders have to be routinely reviewed and reordered, just as they do for antibiotics and opioids. Circular supply chain is a complex and multifaceted area requiring procurement policies that prioritize reusables, evaluating custom packs, and engaging with clinicians to have everyone critically review their habits and drive demand for reusable products. The last pillar of clinical services mobilization is what I'll introduce now, and I'll finish by leaving you with your mission. The idea behind this is that we want every clinical area within the hospital, the wards, the ICU, emerge, etc., to identify high-impact actions they could take to lessen their respective environmental footprints. There's no one-size-fits-all strategy here, and we want to empower people to take meaningful environmental action within their workplace. Ideas that meet certain criteria will be evaluated and implemented. I've been working with the EES team and with the Transformation Office to pilot the initiative in the OR at VGH with a view to rolling it out across the Health Authority. So you are the lucky inaugural participants, and I would ask that you all try to view your workplace through a lens of environmental sustainability for the next while. We're going to use Spark, which is a new crowdsourcing platform that VCH has introduced to drive innovation. If you have a VCH email, you automatically have access to Spark. If you don't, you'll need to register on the site. Spark functions kind of like a social media platform for VCH, where you can post your ideas and people can comment or vote in support of them. We have moderators who will monitor the site and evaluate ideas according to environmental impact, feasibility, and clinical impacts. Our plan is to select 3 ideas to implement in the next 6 months, and then capture and report back on their environmental impacts. If this works, it can be an ongoing iterative process. You'll be receiving further instructions by email in the next while, and the site is expected to go live next week. So please think about the concepts discussed today to go beyond replacing the light bulbs and actually critically evaluate the way you organize your practice, the clinical decisions you make every day, and the things you use to do your job where you can make a meaningful impact. Maybe we need a more robust regional anesthesia program, alternatives to styrofoam for patient positioning, or exploration of any number of reusable alternatives to the things we currently use. I'm excited to see what you all come up with. Just like COVID, climate change is a global public health emergency that requires urgent, coordinated action based on science and healthy public policy. We've been told for years that the solutions to climate change are too complex and that it was too ambitious to expect major structural changes within a decade. COVID has shown us that it can be done. Through the most impressive coordinated action and collective mobilizations of our lifetimes, we flattened the COVID curve in BC. It's time to apply the same effort to resuscitating the health of our planet and flatten the climate curve. Thank you.